Well, I think the countdown has commenced, and I'm very pleased. I thought I might not have been back in time to introduce Margo, and I really wanted to, because I've worked with Margo for 4.5 years now, and she's been an essential part of the International Research Centre for the Advancement in Health Communication, and was originally there as a project manager, then a postdoc, and now she's a research assistant research professor, or research assistant professor. Yep. So the research that Margo is going to talk about this afternoon actually began with an interest that, I have to be honest, say Margo picked up on, and I was lucky enough to get funded for it, but Margo did most of the work as usual, on communication at the end of life. Because it was quite clear that COVID was affecting many aspects of care. And we thought mostly about care being, people in hospitals and just getting sick or not being able to get appointments. But there were people with end of life situations, or people in aged care. And suddenly the world was closed to them, and they were not able to be with their family and friends, and some of them were at the end of life stage. And the centre is really about connecting with the community. So we look at, yes, doing research, academic research, and getting publications on any aspect of health communication and healthcare. We also engage with clinicians because we want to involve them in anything we do when we can, because they're at the forefront of a lot of the work, and it's important to work with clinicians to find out what they want and to find out from them what we need to know. And finally, the community. We want to work with the community. We are a very applied centre. We want to do translational, transformational research, and this is something that Margo is very good at. So we got this grant, I say we, but and then Margo developed it even further and successfully obtained a GRF, which is going to commence at the beginning of next year. So this work that Margo is presenting today is at very early stages of what will become and is a much bigger project. As I said, Margo is a research assistant professor at our university and a member of the management committee of the International Research Centre for the Advancement of Health Communication. She's been a key part, a cornerstone of that centre, as have many other people, but today's Margo's talk, so I'll only talk about Margo. Margo has specific interests in knowledge translation, health literacy, identity, ethics, and group interaction. Close to my heart, that one. Margo was just recently the recipient of the Faculty Award for Teaching. So not only does Margo do very good research and has the position of Research Assistant Professor, she's also a stellar teacher. So I'm now going to hand over to Margo so she can talk to us about communication at the end of life, an initial study of communication and interaction in community-based services. Over to you, Margo.
Thank you very much, Bernadette. Bernadette, can you hear and see me okay, just before I start?
I can.
Okay, thank you. I shall minimize that and just imagine all the friendly faces that are looking at me. Thank you, Bernadette, for that very kind introduction. As Bernadette said, we have worked closely together for a few years now. And the latest topic, really that emerged in 2020 that was of particular importance and interest to us was communication at the end of life. Okay, sorry. So brief pause there. So this is an outline of what I'm going to talk about today. And as Bernadette said, this is an early stage research project. So I will be presenting background, in a sense, to the topic itself, and I will draw on some information that we collected during our preliminary pilot study in 2020. But then I'll also build the research agenda that we're looking to pursue over the next couple of years using that GRF funding as well. I'm aiming to talk for about 35 minutes. I would really appreciate some discussion at the end. This is a very special topic. that has relevance to all of us at different points in our lives. It's a very special topic, but it's also very sensitive as well. So I would welcome any discussion or opinions that people would like to express in relation to this. So in terms of the way that I'm approaching the talk this afternoon, I'm going to define what I mean specifically in this context by end of life. And I'm also going to look at some current directions in research, policy and practice that have shaped what we have done so far, but also influenced what we intend to do over the next couple of years. Now, being a communication researcher like Bernadette as well, I'm going to be looking specifically at communication in end-of-life care with specific relevance to non-clinical workers. I'll then talk about the preliminary pilot study that we did in 2020. And then, as I said, I'll draw that together into the research program we're looking to pursue over the next couple of years. Before I begin, though, I would like to thank and acknowledge some very important contributors to what I'm going to talk about this afternoon. Firstly, the research team from the work in 2020 and going forward as well, Miss Ivy Wu and Bernadette Watson as well. Ivy was instrumental in undertaking the research work in Hong Kong, which really gave local significance and shape to the research that we did. And I would also like to acknowledge our research participants. Anyone who has undertaken social research will know that our work depends entirely on the people who so generously share their time and experiences with us. So hopefully in all the work that we do, we reflect accurately the stories that we are told. So to begin with, I'm going to define what I mean by the end of life in this particular research context. The term end of life is in a lot of ways self-explanatory. However, I'm talking about the end of life in the context of planned or anticipated death. So it has quite particular boundaries in terms of policy and practice. So the Hong Kong Health Authority defines the end of life as the period in which terminally ill patients who suffer from advanced, progressive and irreversible disease fail to respond to curative therapy and have a short life expectancy of days, weeks or a few months. And that's a definition that is shared with other regions and countries as well. So in the UK, the end of life is referred to as the period when people appear likely to die within the next 12 months. And similarly, the Australian Medical Association defines the end of life as that part of life where a person is living with and impaired by an eventually fatal condition, even if the prognosis is ambiguous or unknown, but it has no cure and death appears imminent within the foreseeable future. So in terms of conceptualizing end of life around those sorts of definitions, you can start to see that there are going to be very particular care practices that people experiencing anticipated death will be looking for. So end of life in this context is not a single experience. There are multiple stages that cover the end of life period, and these are often referred to as pre and post bereavement periods. And what's really important about this in the context of our research and our developing research agenda is that across these periods, multiple people are drawn into care and support for people as they approach end of life. And people who are commonly drawn into this period are, of course, families and friends, clinical staff, and also non-clinical workers. And importantly, end of life can unfold across various places. Hospital and clinical contexts have traditionally or historically been the place in which most anticipated death occurs, but what we're seeing is an increase in non-clinical places or residential or care homes in which people are able to sometimes choose to die. So the end of life period incorporates social practices such as death planning, funerals, memorials, and commemorative events that very importantly mark the passing of life. Now, end of life practices are, of course, shaped by social and cultural influences, which means that the end of life looks different in different places at different times. Now, there are lots of contemporary influences that are shaping end-of-life care in both a regional and global context. One of the most significant changes are demographic. So aging populations and increases in rates of chronic diseases have changed patterns of death as well. So the proportion of people dying with multiple chronic diseases in later life has increased. Some studies in Hong Kong have quantified what this means in real terms, and the population projections have estimated a steady rise in the percentage of people aged over 65 in a population sense, from 16% in 2016 to 34% by 2066. And this is then linked to mortality as well. So in 2016, there were 46,700 reported deaths in Hong Kong. And by 2066, this is expected to increase to 98,000. And of course, not all of those deaths fall into the expected or anticipated category of death, but that does illustrate that there's increasing demands in terms of end-of-life care. One of the other very significant things that has influenced end-of-life care practices in recent years are technological advancements. Health systems in developed regions have been influenced by the medical model of curative care, which has facilitated extended life expectancy and the long-term management of diseases that in previous generations would have ended life sooner. So what that means, to summarize, is that health systems are getting better at keeping people alive for longer periods of time. And this has, for many people, influenced the time at which they will die. So there are other perspectives on end-of-life care that are influencing the way that we're looking at the end-of-life period in our research. So we've seen great developments in ethical and physical approaches to medical and social care that affects people at the end of life. Notions of patient-centered care and relational care have shifted some focus from the idea of prolonging life at any cost to promoting quality of life. So you can see those differences in terms like curative versus care-based interventions. There's an increasing understanding of the important role of end-of-life workers in offering patient-centered and relational care. There's more known about the practices and behaviours of workers that promote safety, trust, and open communication. And also there's an increasing awareness that these aspects of work are really fundamental to relational and patient-centered care as well. Importantly, from a sociological and psychological perspective, we're understanding more about the impact of bereavement, even in situations of anticipated or planned death. And we know more now about the psychological, physical, and economic well-being of families and communities, and the importance of recovery from grief as well. Now, in addition to these sociological and psychological perspectives on the end of life, there are, of course, also economic consequences of these changing death patterns. From a health economics perspective, increased costs of care can relate from repeated readmissions to hospital for people who are at the end of life. So in some cases, repeated hospital readmissions may prolong life, but can also impact on the quality of life of the individual concerned. So these various influences and perspectives have been reflected in the development of end-of-life policy and practices in different regions. It's been very positive to see an increase in a focus on holistic and patient-centered care that aims to draw together some of these physical and psychosocial aspects of care and work to prioritise the voice and the choices of the service users as well. Lots of policy documents distributed by governments aim to promote joined up working across government and non-government health and social care providers in order to optimise care experiences. So we're seeing a lot more work between healthcare providers and, say, the voluntary sectors or charities as well. And dying in place is also a term that has emerged in policy in recent years. And this relates to increasing choices in terms of where people are able to spend their final days and hours. So there's lots of movements and development in terms of policy and practice. And a study from CUHK in Hong Kong in 2019 found that 80% of elderly respondents who were expected to die within 1 year indicated that they would choose a residential or non-clinical setting rather than a hospital. And in 2017, more than 96% of elderly Hong Kong patients died in hospitals. So end of life is a topic that is being increasingly talked about in both professional and social sectors as well. However, what we have seen in various regions at a global level is that progress is slow and very complicated. So in the UK and Australia, for example, end-of-life care and social support has been a targeted area of improvement for more than 2 decades, yet actual progress has been limited. And of course, there are many factors that influence that slow progress, and a lot of it is to do with the complexity of the various issues involved in end-of-life care. However, we are seeing some very positive signs in terms of the development of end-of-life care outside of hospital and clinical settings. So as I said before, there is some evidence that in some regions there's increasing choice in relation to where the end of life may occur. However, that is a very complicated topic to address. If you start to look at what actually needs to be done in terms of increasing options for choices for end-of-life care, then you need to look at what sort of settings may be drawn into the provision of that end-of-life care. And for all of these settings, it means they require appropriate infrastructure and access to relevant equipment that can be used to provide comfort in the end stages of life. And that medical equipment is most often associated with clinical or hospital settings. So that's something that influences the slow progress of shifting end-of-life care to non-clinical settings. And the other major factor that's been identified for non-clinical settings in terms of providing end-of-life care services is making sure that there's physical space available for service users and families at the end of life. And of course, there's also complicated but important issues associated with facilitating choice and directing attention towards social and cultural preferences and the careful management that requires. One of the most significant factors, and which drew our attention to this area as needing some more research focused on it, was how you expand the non-clinical end-of-life workforce in order to provide some of these additional services. When we look at the end-of-life workforce, it's a very diverse group of people. We often initially think of medical staff in inpatient, outpatient, or palliative care services. It also draws in social workers, clinical psychologists, and allied health professionals as well. So people who represent what we consider to be regulated professions. We also have counsellors, religious workers, funeral service providers and planners, mortuary service workers, and informal and volunteer workers in non-government organisations and charity services as well. So the end-of-life workforce is diverse, and when you look at taking policy and turning it into practice, you need to stop and consider how all of these workers are drawn into providing high-quality, optimal care at the end of life. One of the very significant factors that we found in our research was that significant work has focused on the clinical end-of-life workforce, but less is known about the needs of the non-clinical workforce, particularly those outside of regulated professional groups like social workers, for example. Yet when you look at all the government policies and plans in terms of expanding end-of-life care and moving outside the clinical setting, it's this very diverse workforce that will have to carry some of that responsibility. The other thing, or other sector or factor of work that has been explored in recent decades in terms of end-of-life care work is a focus on the experience of emotions for workers involved in end-of-life care. And this really developed as a field in the early 2000s. And this work has drawn attention to the importance that relationships play in the ability to provide compassionate end-of-life care. Something that's very interesting about these relationships in end-of-life care and that differentiates them from clinical relationships is that these relationships are often based on intangible factors. So clinicians often draw on their expertise in terms of their communication and interaction with patients or service users. So the doctor or the nurse, for example, have very particular expertise within their clinical practice. But the relationships that seem to matter often in end-of-life care draw on different intangible factors. These intangible factors involve workers investing emotions in what they do and how they interact with people and their families or carers. And it's this emotional investment that makes relational and patient-centered care possible in the first place. Importantly, this emotional investment has also been linked to safety in the care environment. But as always, workforce development in terms of extending the emotional involvement, the emotional capacity of workers is expensive. And the limited amount of research that has been done looking at emotional investment in end-of-life care work has found the training involved to be quite expensive. So in terms of looking at these needed and important developments within the end-of-life care workforce, there are some very important challenges facing end-of-life care workers and the organisations that seek to employ them. So as I just said, the investment of emotions in compassionate care is vitally important, and that has been demonstrated in research from across clinical and non-clinical sectors. However, we do know that investing emotions in compassionate care comes at a cost to the worker involved in terms of their own experiences of grief after somebody dies. Studies have reported that more than 50% of end-of-life care workers report at least one grief-related symptom in response to the death of each service user. So if we pause and reflect on that figure, for somebody whose whole working life is involved with supporting people at the end of their life, then that emotional investment and emotional demand will be quite high over a period of time. There's also been a phenomenon identified and discussed and described in terms of disenfranchised grief. And this is something that is dominant within the end-of-life care workforce. Now, this disenfranchised grief occurs when the worker feels that they do not have the right to experience a significant degree of grief. So there are certain expectations about the grief that a spouse or a family member or friend will feel when somebody dies, but quite often workers do not have or do not feel that same right to claim legitimate grief, and that contributes to this idea of disenfranchised grief. And these grief responses contribute to the very high levels of burnout and occupational distress that is seen in the end-of-life sector. Now, importantly, stress, dissatisfaction and depression in the workforce increases risk of errors and a consequent decline in the quality of care experienced by end-of-life service users. So a lot of this research, as I said before, has been done on clinical workers. Less is known about what happens in the context of non-clinical workers. Now, non-clinical end-of-life workforce has even more unique challenges to contend with. The end-of-life workforce is described in some literature as fragmented. As I said before, when I talk about the non-clinical workforce, it often incorporates non-professional workers such as volunteer workers or sessional or part-time workers as well. And in some regions such as the UK and Australia, a lot of workers employed in the non-clinical end-of-life workforce are not only part-time, but they're also low-paid workers with limited access to training opportunities. So taking these challenges together is really important when we look at the expectations that are potentially put on the non-clinical end-of-life workforce, and as we seek to advocate for more research and development for these workers. So in terms of communication and end-of-life work, communication is key to work anywhere and any sort of health or social care. But there are certain dimensions of communication that facilitate what we call relational care. And some of these involve taking time to interact, directing personal attention towards individuals and families, and supporting open discussion about various topics related to death and grief. So although it's described as communication, I'm sure you can see from the way I put it there that it's very complex communication and sensitive communication as well. And research has also identified that effective communication at the end of life stage is what service users have described as companionship. and that companionship is key to their experiences of end-of-life stages. Now, physical proximity, which is referred to as proxemics, and time, chronemics, in terms of communication, are some of the key factors that have been identified in terms of communication work at the end of life. Some other interesting factors that have been identified in research into communication in end-of-life work relate, and this is feedback from service users and families as well, is that service users and families have focused on the type of communication as meaningful rather than the quantity of communication, and that the type of communication is more likely to contribute to positive post-loss outcomes for families and friends. So it's not just a case of having communication, but it's a case of having communication that's meaningful and compassionate and appropriate to the life needs of the service users and their families. However, once again, these links between relational care and communication, as well as worker resilience, has not yet been studied in detail for the non-clinical end-of-life workforce. But what we can predict is that research from other sectors has consistently identified positive communication as an important variable in job satisfaction and stress management for workers in jobs with the intense emotional demands that you see in end-of-life care work. So that background brings us to the research project which we undertook and that I worked on last year with Ivy and Bernadette, that we positioned as being a research project that looked at the new front lines of infection control. So 2020 and 2021 were, of course, challenging years at a global level, and we've all experienced the pandemic in different ways, influenced by where we are living and also our particular life and lifestyles. But in 2020, what we saw was significant changes to the ways and places in which we all lived and worked. And I've included a photograph there of a shopping centre, a grocery shop, and we're all becoming increasingly familiar with some of the infection control regulations that we have seen rolled out into different social settings. So, for example, on public transport and in many grocery shops as well, we all see and are becoming more familiar with the presence of masks, gloves, and social distancing reminders as well. So in terms of work and workforces, these changes have had quite profound impacts on all of us. But some of these impacts are likely to be greater depending on the sorts of jobs that people have. Now, some early stage work has been done looking at the impact of these changes in work, and DeFilippis et al. Described what we've seen as essentially an unprecedented natural experiment in terms of how these changes will influence our resilience at work and our ability to productively do our jobs. So, as teachers, perhaps, and researchers, we've all found that we've had to switch at various times to online working or online communication as well. But unarguably, some jobs are more suited to these sorts of modifications than others. So when we reflected on some of the diverse impacts of the pandemic in 2020, we started to wonder how these changes in work and workplaces would affect health and social care workers whose occupations are based on intense and relational work with other people. And then we had questions about how these changes affect the health and well-being of these workers. And end-of-life care, as Bernadette said during the introduction, is a stage or a feature of care that we have seen impacted even in regions like Hong Kong and Australia, where prevalence of the COVID virus itself has been relatively well controlled. So we have seen unprecedented changes and restrictions on the way social care can support people at the end of life. So the service users, but also families and communities more broadly. So we had these questions that related to communication, healthcare, but also the emotional resilience of the workforce as well. So what we set out to do in our pilot study last year was to look at these workers in end-of-life care who rely heavily on interpersonal communication and who we also know experience high levels of emotional investment in what they do. So the jobs of these end-of-life workers are often predominantly made up of communication and interaction. So unlike some people who can adapt their jobs to be desk-based or develop things at home and work online, if you're an end-of-life care worker, the very essence and purpose of your job is challenged because it builds on the need for communication. So we also know, as I said before, that burnout and job exhaustion amongst these occupational groups is usually high, and that this affects productivity and clinical safety. When we looked at the workers affected by the different sorts of pandemic regulations in different places, we also looked back at a lot of the research that was done after SARS in the early 2000s as well. Now, there was, of course, a lot of research done that looked at the impact on workers of SARS, but a majority of that research focused on the experiences of clinical workers. Something that was very interesting that emerged from some later research that looked at the impact of SARS and other health crises on workers was it was often non-clinical workers who reported greater stress and trauma as a result of changes associated with that health crisis. And some of the reasons for that greater stress and trauma were associated with the fact that they had to deal with health and clinical issues that were beyond their areas of knowledge, expertise, and preparedness. And of course, what we've seen through this COVID-19 pandemic that is different to previous health crises is that the impact has been far more diffuse and across our lives. So it has not been as contained to clinical settings, but rather the impact of COVID-19 and the infection control regulations have influenced more and more areas of our life. So taken together, we wanted to look at end-of-life care in the context of the pandemic and the changes that workers needed to adapt to. So we undertook a preliminary research study. The research design was a two-stage exploratory mixed methods research project, and we drew on some key theories that have been used in communication and sociological research across a variety of fields, particularly communication and emotional labour theories as well, which I'll talk about in a moment. But just to give you a brief overview of the design of the research itself, stage one involved a cross-sectional self-report online survey, which we used to collect demographic details and also to get people to complete a couple of emotional job demand scale and an emotional labour scale as well. So as I said, this was a pilot study and it was completed by 20 end-of-life non-clinical workers in Hong Kong and Australia. So it was a small-scale study and the people who participated did a great job in terms of providing feedback on the combination of those surveys in that particular format as well. And then stage two of the research project involved semi-structured interviews with survey respondents who volunteered to participate after they completed the online survey. So we had 6 participants in Australia and 3 in Hong Kong as well. And thanks to research colleagues, participants were able to complete the research activities in either English or Cantonese, and then the data was analysed in the source language, and we have had some of the findings translated for the purpose of publication. So I just wanted to briefly introduce a couple of the theories that guided our research. You may be familiar with Hochschild's work on emotional labour, which is she began publishing in 1983 in a book called The Managed Heart. So this particular work explored how individuals used and suppressed emotions in the course of their employment as they tried to meet the perceived requirements of the employer and fulfill occupational tasks as well. So Hochschild's original work focused on airline workers, but it has been extended significantly in subsequent decades to look at workers across a variety of fields. And to look at how we each deal with emotions in our job, but also what happens when you suppress or manage emotions and the impact that this can have in the medium term on resilience and burnout as well. So this work reflected the need, so emotion work, in our occupations reflects the perceived need or requirement to anticipate, interpret, respond to and manage emotions and behaviours of others, and thus influence the state of mind of the customer or the service user. So if you think of somebody working in end-of-life care, as I said before, it's intense and relational work, but a majority of their their actual daily practices could be directed at supporting and managing the emotions of others. So you can then hypothesize or extrapolate that to think or to wonder about what that does to the individual in terms of their own management of stress and grief, and how that can then in turn affect their work performance as well. So emotional labour and emotion work has been used in various fields such as teaching and nursing. And some of the key factors that attach emotion work and resilience are always communication. Communication between individual workers, but also service users as well. So we wanted to take this idea of emotion work and emotion labour and look at it in the context of crisis. So as we've heard words like unprecedented repeatedly in the last 18 months, but what we've seen is workers having to respond to these unprecedented infection control demands, often with very little notice. So we wanted to look at how people in end-of-life non-clinical work respond and adapt their daily practices in the context of this crisis. So we carried out our two-stage study. As I said before, our participants were very patient and provided good feedback. And of course, one of the benefits of doing a pilot study is you can reflect on what worked well and what you would do differently in the next stage of your study as well. So the findings that I'm covering are drawn from both stage 1 and stage 2 of the research itself, and I do acknowledge as well it was a small sample size, but some of these findings correlate or resonate with findings from much larger research projects as well. So they are interesting, even though the sample size was small. And some of these are unsurprising as well. So for example, these end-of-life non-clinical care workers reported high, intense and sustained levels of emotion work between themselves, service users and their families or carers. And what was interesting was that individuals described almost all of their daily practices or their daily work activities as involving ongoing and reciprocal communication with service users and families or carers. So unlike myself, for example, I have a break between relational interaction and communication and desk-based work. That was different for these end-of-life non-clinical workers. Almost their entire day job consisted of ongoing interaction and communication with service users and families or carers. So the communication practices that they described were closely connected with emotional aspects of work and also the individual workers' perceptions of their contribution to end-of-life care work. So, for example, workers often said that being able to communicate effectively with their service users made them feel like they were doing their job well. If they couldn't communicate effectively, then they didn't feel they were actually fulfilling the purpose of their job tasks. So these workers described in general limited access to training on how to deal with some of these intense relational aspects of their work and with the ongoing and changing communication needs of their service users. And individuals often reported having to manage or control their own emotions as they communicated with service users. So some of these findings are, as I said, reflected in broader research studies with clinical staff, but some of the intensity of the emotions and the work demands were unique to non-clinical workers. So when we analysed our interviews with our research participants, we found the greatest impact they associated with the regulations enforced during the pandemic were reflected in ideas of altered communication and also the impact of these changes in communication in terms of their ability to do their jobs. So some of the greatest losses that these workers identified were the loss of time and opportunity to communicate and also the loss of non-verbal communication. What was significant was that there was very limited reference to the loss of verbal communication opportunities. It was the non-verbal aspects of interaction that end-of-life care workers noted as being the most significant loss as a result of the limited access that they had to their service users. Now, the impact of these changes in communication were quite significant in the way that these workers described them. They described themselves as being unable to fulfill their roles, having changes in roles and responsibilities, and having significantly increased workload as well. And these impacts in terms of changes in communication on their ability to fulfill their role were most often associated with feelings of stress and negativity about their work and their ability to support their service users. So I'm just going to look briefly in detail at some of the relevant points about time and opportunity in terms of communication. And I'm going to look at these to then compare them briefly to some of the research work that has been done on clinical end-of-life workers. So time and opportunity to communicate was consistently featured in discussions about end-of-life care in both pre and post-bereavement stages. So end-of-life care workers said that their jobs often require them to go and be with someone at short notice, or if the end of life approaches more quickly than anticipated, and their ability to be there spontaneously and personally was a key element of care and relationships. And these relationships often developed over time and after repeated interactions as well. And one of the participants described these features as making relationships authentic, and it was repeated a number of times that online or phone contact was not an adequate replacement in terms of time and opportunity to communicate. And there's a couple of quotes there from our Hong Kong interviewees. Generally, a part of our services strongly relies on the authentic relationships between service users and the providers, and it's hard for people to connect virtually. And something that was significant again in a number of other interviews as well was the difference between what people can find out about their service users when they meet them in person compared to when they talk to them online or over the telephone. So when I meet them in person, I could observe their look, expression, gesture, physical ability, and their living environment as well. So the end-of-life care worker discerns a lot of information from seeing and being in person, in personal contact with service users as well. So the non-verbal communication aspects that came out of our research were very interesting and quite significant. So the non-verbal communication that was missed from end-of-life care in this context did not relate to conveying information, but rather focused on building relationships and offering comfort or companionship. So that correlated with some of the research that I mentioned earlier on. So non-verbal communication was very important for service users who also had had comorbidities such as hearing loss or dementia. Eye contact, hand-holding, and just sitting alongside service users were features of non-verbal communication that were lost within the context of the pandemic. And once again, people reiterated that there were simply no viable substitutes for these losses in communication, and that the loss of this non-verbal communication came at an emotional cost for the worker, and they perceived for the service user and family as well. And this was reiterated by people who worked in funeral services, and also, for example, in this quote from an Australian priest who was heavily involved in conducting end-of-life care or being involved in end-of-life care, and also at funerals as well. So the lack of physical contact was huge. Like at the end of a funeral, usually you shake hands and you stand with people and say, if you need contact, I'm here, that sort of thing. And they're able to mingle with people who've come, but now they're not supposed to hang around, they're supposed to leave. So the impact of these losses of communication on end-of-life workers were significant, and they were often described in terms of an inability to fulfill the very purpose of their jobs, but also to derive satisfaction and fulfillment from the jobs that they were doing. For example, there's a quote there from a Hong Kong community services worker who said, in our past visits, we talked about advanced care planning or some activities called wish fulfillment. We hope that they're enjoying the activities and that they could draw out from their role as patients so they could also have some quality of life, even at the end stage. And we can't do this right now. And also there was negative energy associated with some of those changes and the emotions experienced by the end-of-life care workers. And one of the interesting quotes, and it was repeated in different ways by a number of interviewees as well, was the stress for the workers when they felt or they realized they couldn't fulfill the expectations of the families or the service users. So as I said before, we conducted this research in the context of the COVID crisis and all of the adaptations and changes that we've all been forced to make during this crisis period. But some people describe service adaptations as well. And this notion of service adaptations in a time of crisis is something that we want to carry over into our future research into end-of-life care communication. So some service workers describe adaptations and attempts at creativity as well. And although these took more time in terms of finding these adaptations to make up for some of the gaps in services, they were productive. And there's one quite lovely one actually here that's a Hong Kong worker described. So the elders are not familiar with using phones, but they're familiar with letters. They wrote lots of letters in the past. Some elders told us that they used to communicate with their loved ones through writing love letters, as one of them was living in mainland China, while another one was living in Hong Kong. In that case, writing letters helped maintain their relationship. Their words strengthened our thought of writing letters. So we asked volunteers to participate. And they did participate. They weren't satisfied by writing letters only. They even sent some drawings, origami, and lanterns as the Mid-Autumn Festival was arriving. So this is an example of an adaptation that workers thought of to try and make up for some of those losses in communication opportunities with their service users. So in terms of contributing to theory and practice in relation to end-of-life care, there's lots of policy developments, and in any region around the world, governments often issue policy, but there's a heavy responsibility on organisations and service workers to actually implement those policies. So it's very important to emphasise from our research and to build on the preliminary work that we've done to emphasise that improving the quality of end-of-life care is expensive, and worker needs need to be incorporated into any attempts to extend services. It's very important to understand more about the communication and emotional labour work undertaken by end-of-life workers. This will increase the resilience of workers and help them to provide better service to their service users. So developing skills and competencies is very important, as well as being aware of the psychological and physical impact of this type of workers. Communication theory is important in any aspect of health or care, but also it's very important in end-of-life care because of the impact on service users, workers, and also families and friends after bereavement. And it's important to recognise the challenges of providing compassionate care. Once again, policy often contains lots of jargon and aspirational statements, but there is a financial cost in terms of developing the workforce, looking at staffing ratios, salaries, and training opportunities as well. So from the research that we undertook last year, we've developed that further, and I'll briefly talk about our future research agenda at the moment. But based on the work that we've done and building on the work of other researchers as well, we are going to look at developing some topics to focus on workforce improvement. So communication, including a focus on non-verbal communication skills, resilience mechanisms, to help workers deal with grief and the death of service users, as well as the grief of families that they quite often have to see. It's important for workers to have access to bereavement care for themselves, and also to think more broadly about what social and spiritual support for people and families can look like at and after the end of life. And also workers need to be supported in developing their understanding of cultural, religious and spiritual aspects of end of life care as well. So I am aware of the time. So the key points that I want to emphasise from the research that we've undertaken was the importance of non-verbal communication. So looking at chronemics, haptics and proxemics. So thinking more broadly about what communication is and moving beyond the focus that has dominated in a lot of communication theories on verbal communication, but considering more about the integral role that non-verbal communication has in end-of-life care, and also the sort of adaptations that can be made and the creativity that's often needed in terms of promoting non-verbal communication. So as Bernadette said to start with, we have secured GRF funding to start a broader research project in January 2022 for 2 years to look at non-clinical end-of-life care in Hong Kong primarily, but with some links and connections to Australian policy and care practices and research that has been done there as well. So our research activities are going to focus on exploring non-verbal communication in different social and cultural settings that offer non-clinical end-of-life services. We're going to focus on looking at the links between communication and emotion work in the non-clinical workforce, and also looking in detail at some of the training needs and opportunities for non-clinical workers. And we're going to find ways of promoting sensitive workforce training that focuses on patient-centered care and resilience work, but without a focus on a competency-based model of communication that usually goes alongside that focus on verbal communication. So skills training is vitally important, but we will argue that it needs to go beyond simply skills training, and workers need to learn how to use and adapt their communication skills creatively. So in terms of publications, if anyone is interested, we have one journal article currently under review that gives a summary of some of the findings of our research project that we undertook in 2020. And then there's 2 other publications associated with that research project that will be coming out in 2022. So I wanted to finish with a quote from a Hong Kong physician and researcher into end-of-life care as well, that I think summarises and reinforces the importance of thinking and investing in end-of-life care that is sensitive and effective for both service users, families and workers as well. So Yvonne Mack said in 2006, palliative care is not about dying and bereavement is not about crying. Rather, they are about connecting, caring and respecting the essence of living. So I think if we look at end-of-life care and communication in both the clinical and the non-clinical sectors in more detail, then we can start to see how the end of life actually connects to the quality of life as well. Okay, there are some selected references. I have included a lot of other references in the actual presentation, so please do email me if you would like a more detailed reference list. So thank you very much. I'm not sure if any